Good afternoon, and welcome to Leveraging Big Data and Deep Analytics to Improve Care, a complimentary webinar from HealthSystemCIO.com, sponsored by SAS. Just a little bit of housekeeping before we get started. My name is Anthony Guerra. I'm the editor-in-chief of HealthSystemCIO.com, and I'll be your moderator today. We encourage questions, and I think we'll have a lot today. Feel free to type them into the Q&A box in the lower right-hand corner of your screen at any time, and you can send them in. Leave the default set to all panelists, and we will take those later in the program. Also, you will be able to access the deck, and you can see that URL in front of you. There's also a shortened URL at the bottom of each slide, and I sent it out in a chat box, so if you can grab that from your chat box, you should be able to get the deck. And we will have an archive available of our event today. Should be ready within 2 business days, and a separate registration is required. You get an email when it's ready. Just so you see how we're going to spend our time today, we're going to go about 45 minutes. First, we're going to hear from Deanna Wise, EVP and CIO at Dignity Health. Then we're going to hear from our sponsor, represented by Dr. Graham Hughes, Chief Medical Officer with SAS. And then we'll have our Q&A. We'll bring Deanna back, and she'll be joined by Bill Guides, Senior Director of Application and Information Architecture with Dignity Health. So without further delay, I'm going to pass the control over to Deanna Wise. Deanna, thanks for joining us.
Thank you, Anthony. Hello, everyone. Thank you for giving me the opportunity to share a little bit of our story with you today. So a little bit about me. I've been in healthcare for 24, actually in IT for 24 years. Grew up through the ranks, so came in from an application specialist, and enjoy what I do. I honestly say pride myself in healthcare and love it. So with that said, I'll go to my next slide. Recognizing in healthcare, sometimes we're not the speediest from the technology side. I enjoy this slide. If you're in healthcare, you will definitely understand the humor in it. If you're not in healthcare, you might look at it and go, "Oh my God, that's kind of sad." But we are a little bit behind in our technology. We are advancing and very proud of where we're going. So as I move to the next slide, healthcare costs are projected to be 26% of the GDP by 2035. Today, we spend about $9,000 on our average per person in the U.S. Our challenges include, I'm going to end up with a stuttering tick, decelerating price growth. Historical average increase for Medicare was 3.2%. Projection for 2014 forward is 2.3%. Continuing cost pressure. Annual cost growth from 1989 to 2009 was 3.6%. 2010 and beyond is projected at 4.4%, driven primarily by nursing shortages, IT investments, which are significant, and increasingly complex care. In addition, we have shifting payer mix. In 2011, Medicare and Medicaid accounted for 59%. This will continue to increase and is projected to be 72% in 2021. Lowest margin business growing by 13%. Deteriorating case mix as well. Aging and the rise of chronic disease medical cases threaten to crowd out more profitability procedural volume. Our readmission rate is something we all monitor. 1 in 5 people are readmitted to the hospital within 30 days of their discharge. What does all that mean? Cost increases are not sustainable, and we have to operate differently and break the trend in healthcare. Provider incentive schemes are shifting from fee-for-service visits to pay-for-performance to managing risk and total cost of ownership for populations, various shared savings contracts. Success metrics are changing too. In the old days, raw numbers of procedures and visits were indicative of performance towards cost per episode, and entirely new risk-based metrics targeting at keeping population healthy is where we're headed. It's a new world. It requires new IT capabilities to enable things like risk stratification, prediction, and management tools. Patient attribution capabilities. Patient connectivity is key. I, as a healthcare patient, want access to my data. It's imperative that I understand it. Population health management, registries, and various components. In the past, we dealt with primarily CDC and things like that, but now it's a whole different world. We need to become excellent in managing risk, creating business rules engines that combine vast quantities of data from disparate platforms to produce triggers that drive behaviors of care coordinators and patients. We have so much data coming in the face of our clinicians that we really need the tools in order to help them point to what's most critical versus the alert fatigue. Connecting enterprise data is key to our future state. Today's business model, we at Dignity Health are migrating from a hospital company to a physician and continuum of care company. We are going from core competency, facility management, and cost management to population management and growth. In addition, point of differentiation, scale and systems to patient and staff experience. Because if they don't enjoy and find benefit of using the systems, frankly, they won't use them. And why should they? At Dignity Health, we have Horizon 2020. Dignity Health has a great vision. Its IT will continue to play a vital role by ensuring we have the right foundational technology capabilities in place to run our operation, but even more, create next-generation capabilities that help us leverage our data. Connect business processes in a very creative way to offer new business capabilities that consumers need and want across the continuum of care. We spend a lot of time focusing on what is important to our staff, not just our clinicians, but also our technology team, and focusing on making sure that we create an environment where it's fun and they have an environment where they want to come to work every day. Moving forward in innovative opportunities like this allows us to create that environment for our clinicians as well as our employees. Analytics is one of the many transformational IT initiatives across the continuum of care. Big data is really important, but one of many strategic initiatives we are progressing. It's, as I mentioned before, what's most important about this slide is thinking about placing the patient in the center of their health. You notice I didn't say health care. It really is about how to keep the patient healthy and out of the hospital. And as you look at organizations like Dignity Health, we're looking at various other components to migrate into the business from the healthy side, not just from the patient care side. The age-old adage, you can't manage what you don't measure. So I think what's really important here is we want to take on large segments of population through commercial arrangements and other partnerships and be able to know what has happened, what is happening, and what will likely happen to our members. The better we get at this, the better the outcomes for our members and for Dignity Health's financials will be as well, which is all important because the truth is, as much as we're in it for the patient and our mission is all about the person-centered care, the bottom line is with no money, we have no mission either. So it is important to protect the financials of an organization as well. So big data analytics, definitely the foundation of our transformation. I, like many of you, I suppose, it's amazing how many emails we actually receive in a day that it's possible to get that many when you look at. So I thought this was a fun slide to take a look at the statistics. Google receives over 2 million search queries. I, like you, I'm sure, go to Google about every time I'm looking for a simple question. That's where I go first. To target what I'm seeking an initial answer on something, including healthcare. A full 90% of the data in the world has been generated over the last 2 years. When you look at the IDC actually says that the world has, in 2013, we created 4.4 zettabytes. That's pretty amazing. So if you think about that, it actually has 21 zeros. There's a 1 and 21 zeros following it. Can you imagine if that was the price of the systems that we would need to pay for that data? So the truth is that big data has went down in cost. And so the value of being able to do this is definitely there today. Big data is really big, and it grows by 50 times by the year 2020. Data is the new gold. We've spent a fortune implementing EHRs, and I know my leadership team would put a capital F on that fortune. It's very expensive to put these basic systems in for electronic health record. And then when you look at it, you're like, okay, well, what next? We have all this data, and it's coming at you in so many ways. How do we really leverage the information, compile it from our electronic health records, as well as for our financial applications, in addition to the biomedical devices that we have? I know in many cases, you're leveraging the various data marts and things, but for us, it's really how do we pull that data all together and be able to deliver information directly at the bedside so that the physician and the clinicians can actually do something at that moment, not later looking at historical reports and saying, oh, if we modify this particular procedure going forward, here's what we would be able to do, but literally having the information inserted at the bedside into our electronic health records where it can really make a difference for that patient at that time. How will our big data platform deliver real value, lower cost, increase revenue, and improve clinical outcomes? Okay, this is a really busy slide, but the focus here is business optimization model. We actually pulled this from an IBM deck, and a very impressive focus here is strategic outcomes is the gray outer ring, business competencies, functions is the green inner ring, and then business initiatives and processes, the area in the blue where analytics can be applied to drive enterprise value. The green pegs are where our group of executives thought we should start our first analytics journey. There are many other areas to begin and to focus on as we go forward, but as everybody knows, you have to start somewhere. Building the right group of executives to help prioritize initiatives and sponsor operational deployment across our facilities is key. If this is seen as just an IT project coming in, then we will never be successful. It really has to be, as all IT projects do, is partnering with the business, coming together and understanding and building a correct governance model in order to make sure that you're focused on the right priorities, not from a technology side and not just from an executive side, top coming down, but really get the right people together. So it really is about the business alliance to succeed and can run effectively only effectively as an IT initiative. We are spending a great deal of effort ensuring we have the right data governance process in place. I'm not saying this model here projected is perfect, but what I am saying is there is a strong focus at it, and then you tweak it as you go, and we will be aligning it as needed as we go on this journey. So you might say, what are you going to do here first? It sounds like you've got a lot to do. Where do you start? We actually selected 4 use cases to start with our EDW journey. We are, congestive heart failure, acute care and readmission rate, 24/7 sepsis surveillance reduction across all hospitals, pharmacy cost reductions, enterprise patient encounter data warehouse. So the last bullet is a fancy way of saying we're going to actually streamline our reporting process, because also in healthcare, as you can imagine, especially as an entity our size, from a technology department, we're getting requests from everybody from various reporting requirements. So leveraging a tool like this and being able to streamline that and be much more effective. If one hospital requests it, surely it's a benefit to another hospital, and ensuring that we leverage our size and knowledge base across the organization. In addition, when you look at the pharmaceutical spend on a market basket, there's a huge amount of dollars that are going into there. And what a better place to start to focus on patient care and alignment of our spend as an organization. So as we come across this question and we started our business case of understanding the needs and the value of a system such as this, what do our providers want to know? Can you give me information that helps me prevent adverse events happening to my patients? And again, it's right there at the bedside. It's not about, can you tell me a month later what I should have done last month, because I may not remember all the particulars. So it's really inserting the information at the bedside. And how can I receive more useful information and less noise? I talked about so many alerts coming at them that it really becomes alert fatigue. I mean, we all know that sometimes we get some funky error that comes up on our screen as we are booting up our machine, and how many times do we click past that and go, I'll deal with that later? Well, physicians are no different, and when you're talking about patients' lives and care, we can't afford to do things that way. In addition, do order sets make a difference? Sometimes we get accused of having too many order sets, and so how do we really streamline those and understand, based on data and facts, evidence-based medicine, of where the benefits are, and how do we streamline those? So I'm very proud. I don't have today with me, but my executive sponsor is our Chief Medical Information Officer, Dr. Kalarafi, who is very passionate about what we're doing here. And so we have complete alignment with our quality of care. And that's what it's all about at the end of the day is, like I said, putting the person in the center of their health care and really focusing on what makes life better from a physician standpoint and how do we improve the care for our patients. So on this slide, just bringing you a visual and interactive knowledge to the point of care so that you can kind of understand the flow of where it's going. We're really talking about integrating services the clinician really want within their regular workflow. If we make it difficult and we give them something different or clicking to another screen or various applications, it becomes challenging for them. They only have so much amount of time in a day, and many of them are doing their rounding as they're also seeing patients in their office. And so how do we make it easy and seamless? So it really is, again, about putting the information right at their hands and fingertips. Dignity Health has lots of pockets of analytics at an enterprise. As I mentioned, we have several data marts in various places. They're generating value. With that said, especially given the relatively small investment we've made in them, but many of these data marts, like our AIM platform, serve a wide array of customers and multitude of needs. So when we saw this, we said if we could do this at a bigger scale, we could certainly bring more value by bringing the data points together. So our EDW, or what we are calling the DHI platform, which stands for Dignity Health Insights Platform, will take us to an entirely new level. We are targeting breakaway capabilities and planning on leveraging big data and the right partnerships to get there quickly. You know, I mentioned AIM, and we are terrible and notorious in IT as well as in healthcare specifically for giving you acronyms and not telling you what they mean. So AIM is actually our name for Analytics and Information Management. Their charter is to develop and implement data integration, data aggregation, and business intelligence reporting to support the clinical, operational, and business needs across Dignity Health. So I mentioned a moment ago the Dignity Health Insights. Here is a picture of what that looks like. The exec summary version of our reference architecture for the Dignity Health Insights platform, so you can really get a visual of what does this mean. Tools and capabilities will be added to the stack incrementally as required by use cases. Everything we do is focused on transparency, insights, collaboration, and operationalizing capabilities. Let me repeat those because I think that's really important. Everything we do is focused on transparency, insights, collaboration, and operationalizing capabilities. We will enable a Lean Sigma focus and are practicing benefits-driven implementation. In this, as we develop it, we're building an open architecture as there will be many complementary capabilities, both internally and externally created, that we plan to plug in over time and hopefully we're expecting many interesting partnerships and opportunities. And Cerner is an example of that. So as we develop this data health insights, you know, maybe there would be applets or various things that would be able to, now obviously when I say that I want to make sure I clarify, there would be security and HIPAA compliance. But opportunities where applications could plug in and be developed to, again, enhance the workflow for a clinician or enhance from a patient perspective so that I have better access to my data and what's important to me. Maybe it's a case of that I'm on my patient portal and I need a cab and I'm leaving the hospital and I've had some type of injury or something requiring that I need a cab. And so at that point, maybe within a click of a button, there is an applet that obviously, tells the patient or tells the cab services exactly where you are in the time and where to pick you up. Just a silly example maybe, but an opportunity out there for innovation. So I'm excited to say, so the big build-up here is we are partnering with SAS. I know you'll hear from Graham here shortly. We are super excited that he has joined actually this webinar with us. We're very proud of where we're at with the relationship. We feel like SAS is a great cultural fit to go with Dignity Health. We have a very aligned, I would say, mission and vision of where we're going as organizations. They have the best tools to answer all the questions from what to what now, and undisputed world leader in predictive analytics, which is what we feel will be the single most important differentiator in managing risk and population health going forward. So, Anthony, I will turn it back over to you.
Okay, Deanna, very good. So you're all set there. And now we are going to bring in Dr. Graham Hughes with SAS, and he can do his presentation and react to the glowing review he was just given.
Yeah, thank you very much, Deanna, I really appreciated the clarity that you had there, laying out both your vision, which is, as you say, tightly aligned with what we're trying to accomplish. Just a quick introduction. I'm Graham Hughes. I'm the Chief Medical Officer at SAS. I've spent the last 25 years in health information technology, and having started out a career in medicine in the UK. In my role as Chief Medical Officer at SAS, I provide clinical input to our product direction, and I lead an innovation team that's focused on application of our advanced analytic capabilities to health and life sciences. As I say, it's a privilege to be working, and I have the privilege to work on a day-to-day basis with organizations across the spectrum of healthcare delivery, from pharma, med device, payer, and provider. And it's a true privilege, as Deanna mentioned. I just reciprocate, which is that really working with an organization that is as broad in reach as well as in its thinking as Dignity Health, and the approach that they've taken to bring in external talent that has analytic expertise from other industries, I think is something that we're starting to see adopted by others. And so Bill Geis, who's also with Deanna, has come into healthcare and has applying all of the some of the best practices, I would say, that he's learned in other industries and applying them quickly to healthcare. And I think there's an opportunity there for all of you on the phone to think about how you can leverage best practices from other industries. So our focus obviously is to improve health, as Deanna mentioned, improve health care and control costs. So the focus of the triple aim. My next slide is somewhat of an eye chart, and I don't expect you to read it, although if you do get the chance and you want to peruse it afterwards, then please do so. It shows, in many ways, it's a visualization, and it shows the value of visualization, I think, in understanding complex data sets, complex environments. What this is showing is the impact of the Affordable Care Act in both financial and clinical dimensions from 2011 through to 2016 and beyond. And we've tried to take the axes here based on our understanding of that and the discussions we've had with customers across the industry in 4 different quadrants. So at the bottom, the clinical quadrant is focused on quality and outcomes, and you'll see various initiatives that have been driven by the Affordable Care Act as well as high-tech stimulus funding. And you'll also see then at the top end that we have payment and cost initiatives associated with financial imperatives. Each of you, will understand and realize that essentially what this is showing is it gives you the oh crap moment, that there's just way too much going on for us to deal with, and that as we look forwards, these major initiatives that focus around value-based payment are all pervasive. And essentially what it means is that for those organizations that are taking the challenge of value-based payment to heart, is that it isn't just an incremental small hop from fee-for-service to value-based payment models. It requires that you fundamentally transform the entire business. So you don't just jump from one of these peaks to the other. You have to go all the way down, re-engineer your business, and start to work your way up the other side. And foundationally, it's our opinion, and I believe that it's also Dignity Health's opinion, that data is a significant component of enabling a transformation within your business, and particularly understanding risk and future-looking analysis. What can we do to predict the journey, and what do we need to do to minimize our risk during what you can see here is a fairly dangerous and journey that could be fraught with problems. And so that leads us to really go back to the title of what I wanted to wrap this up with, which you'd heard Deanna allude to in many ways, which is value-based healthcare requires a different way of doing business. There are risks and opportunities here, new opportunities for a business transformation that doesn't look like it does today. Certainly doesn't look like it did 5 years ago, but it's an opportunity to transform your business, look for new opportunities for revenue and new ways of structuring your organization. The 5 pillars that I would highly recommend that every organization who is listening in has a plan to address are these. So managing the financial risks and incentives associated with new payment models. That is a prospective exercise because you need to plan and understand what that means in terms of overall financial risk as you transition and potentially cannibalize existing revenue streams. And there will be a journey so that as you do that, portfolio understanding and optimization becomes critical. It's been done in other industries for years. We have to start doing it in healthcare. Proactively managing care quality and outcomes, less to do with the hundreds or thousands of quality reports that you have to generate today that are overwhelming your capacity, and more to do with how do you predict those key events or areas that you need to intervene in now to keep your care quality and outcomes at the highest possible level. So again, much more of a prospective, predictive, future-looking way of thinking about care quality and outcomes, not retrospective or rear-view mirror. Then the other is efficiency of care delivery. This is whether it's supply chain management, ED throughput, scheduling optimization, OR management, understanding waste and inefficiency and supporting a lean-based initiative. Data is the only way to get to the bottom of that. Data is the only way to sustain that. And modeling out and predicting and simulating environments in which we change our business can have unintended consequences. And many of you will have familiarity with having proposed that you open a new ambulatory center or maybe an oncology unit only to find out that the volumes weren't exactly what you expected, or that the predictions that you had made had not panned out well. So getting excellent in that area is going to become extremely important. And then, of course, where's all the buzz? If you're managing risk and moving towards a more capitated model, it's much more around engagement. It's much more around population health. That's all about risk stratification. It's all about understanding preference, and it's all about understanding how you can manage the behavioral economics associated with the individual patient, as well as populations of patients. You can't do any of that without having your information management and data management framework solid and in place, and I'd say you have to think about that at an enterprise level. If you can have strategies associated with all 5 of those, your business will probably be around in 2020. If you don't, I would suspect that you're going to have trouble. And with that, I will hand it back over to you, Anthony.
Very good. Well, thank you very much, Graham. Appreciate it, and appreciate SAS sponsoring the event today. So now we have about 15 minutes for our Q&A. As I mentioned, go ahead and send your questions in the Q&A box. Leave them default set to all panelists, and we will pose those to Deanna and Bill. Bill, first off, I want to thank you for joining us.
Thank you.
Very good. All right, my first question is going to be for you, Deanna. Big data is obviously a huge buzzword. I can imagine that a lot of CIOs in healthcare are getting a lot of pressure from the rest of the C-suite and the board to make magic happen under the guise of big data without maybe understanding what it takes. What would your advice be to CIOs out there in terms of setting expectations and educating the C-suite and the board about what's possible, what's not possible, and the resources required to achieve what's possible?
So my advice is always to be transparent and bring the business into this. I am a strong believer that we spend a lot. We as companies, industries, spend a lot of money on technology, and I think that we have to be careful that we're not just buying technology or doing technology for the sake of technology. It really is trying to solve business needs. So making sure that you always have a core business sponsor that you're partnering with. In my particular case, it was really interesting when I sat in my first executive meeting and was trying to articulate why this is so important. I was able to actually sit back and take a pause, and my peers from the quality side, from my COO of the organization, as well as my strategy guy, jumped in and actually sold why this is so important. And my CEO looked at me and said, okay, I get it. And so I think the value is that it's not the CIO sending and always delivering the message, that we're there to enable and to develop the strategy, but you've got to partner with that business to make sure you're hitting the right mark.
Okay, great. Tell me if this question rings with you, because I'm not sure. How important is developing proprietary predictive risk models versus using established models built on top of your own stacks?
I would say for me, I don't know if it's all about creating what I would call proprietary. I'm looking to do the best thing for the clinicians, and I'll be the first to tell you that I'm not always the smartest one in the room or the organization that's the smartest one out there. We are certainly willing to borrow and leverage the knowledge from others in order to move things forward faster.
Very good. Let's talk a little bit about maybe some things that other CIOs out there with smaller organizations can accomplish. Are there easy wins that come to mind when we talk about analytics that you think are good starting points for other organizations out there?
I'd have to spend a little bit of time thinking about that question, but I think it's always about scale. I do always think I've come from individual-based organizations and realized that it's very tough, but I also think that it's always about how do you scale it appropriately. So maybe you would start and not go to the degree that we're going to of bringing in so much of various data components, but you would start a little bit smaller in order to still meet the needs.
Okay. The analytics lens seems focused introspectively. How do you leverage analytics and big data to measure value and drive quality from vendor applications and services? That's an interesting question.
Yeah, I think the question is exactly right. So as we start, we are looking introspectively. But as we go forward, our thought is to bring data in from the outside as well and to look at it in comparisons. But we are initially starting introspectively.
Okay. With the emphasis on reducing rehospitalization and shorter length of stay in acute care settings, can you address how or if you are doing analytics on the data in the post-acute care setting, home care, long-term care, and how it fits in your overall strategy?
We do. We have the intention. We've got some strengths there. I mentioned our AIM team that we're doing, and we're doing analytics on our ambulatory as well. And since we are a provider of care across the continuum, this is not just an acute focus. It really is a leverage across all of our continuum of care.
Mm-hmm. And you mentioned the use cases that you had started with. Can you talk a little bit about how you came up with those, established those, and maybe folks can have some takeaways there?
I can give a high level, but I don't have Dr. Colarafi on the phone. But from a clinician side, it was really about speaking with the quality and the clinical side. And I don't know if I could punt the question to actually Dr. Hughes, who worked closely with Dr. Colarafi, or Bill, would you want to take that?
Yeah, sure. I could take a cut. So what we wanted to do, back to Deanna's point, gaining the support for our executive leadership, is make sure we had a business case with what we want to do based on reality. So I work with Dr. Colarafi and in our finance team, and we looked at where the underlying cost of the most the critical care services we provided, and both sepsis and congestive heart failure were ones that included a lot of cost, and then there were a lot of opportunities to improve outcomes. So we kind of looked at the corporation at large and just finances and opportunity to provide better care, and picked the top two priorities. That one chart Deanna shared with a roadmap, although it's a bit of an eye chart, has a number of other things like that. And essentially Dr. Colarafi and I worked across the organization. He understood where all the clinical opportunities were and where we think we would get the biggest bang for the buck. And then we just did our homework to find out the actual numbers to build the business cases.
Graham, did you want to comment?
No, actually, I think that Bill's covered that very nicely. It was definitely driven based on a business case and an impact analysis within Dignity Health, led by clinical teams.
Very good. Deanna and Bill, you've both repeatedly mentioned Dr. Rossi. Talk a little bit about what the IT team needs in a clinical partner. You know, what it makes this person so special and good to work with, and has made this relationship work so well. And I think that folks can either, maybe if they're looking for that partner, they can either say we've got the right person or we don't, or it can help them in their search.
I think that's a great question. I think part of the strengths that start with accountability of someone that is accountable and passionate about what you're trying to accomplish or what you see the need is for, and looking around and seeing who within the organization has an interest in it, is important, but really is passionate about making a difference. And that's where you get a great champion versus a good champion. Bill, I'd love to hear your additional thoughts.
Yeah, just one other thing, and we work with Dr. Colarafi. It's not a us and them. It's a we. And Deanna mentioned this earlier, that a program like this absolutely cannot be successful without that key business alliance. And this is all about changing behavior at the edge, at point of care, and you need a clinician's view to make sure that everything we're doing is testing to ensure care will only improve through implementations of the technology, and that's his focus. We have a whole medical informatics team, and they work very closely with all of the folks at the hospitals to make sure we're solving problems they want solved. We test them, and everyone's happy with the things that we're going to roll out. And the passion's certainly there. He really wants to have everything we're doing in analytics be a game changer for the company.
Very good. Deanna, you put up a slide about the data governance. Can you talk a little bit more about any best practices you can think of there when creating a governance structure? Any common mistakes you think folks might make? You've mentioned that there's so many things to do, that governance is really the key to making the right choices, whether it's data, security, or any other area of the business.
I don't know if there's a perfect model of governance out there. If it was, it would be easy. But it's understanding a little bit about the organization, who seems to carry the flags most often, making sure that those people are within your governance model, making sure you have voices appropriately represented, so that you don't be accused, because you will be no matter what, of I wasn't included in that decision. Mm-hmm. And so I think you tweak it as you go. I wish I could say there is an absolute secret sauce to it, but there is not. I think alliance to roll across the enterprise is critical to it as well. That's Bill. Any other?
No, I mean those are the keys. In a system as large as ours, there's so much diversity of need out there, and we're leveraging our governance structure to really understand the voice of the customer. And we're investing a lot of money in building an enterprise analytics capability, and we want to get the value. And where we get the value is maximizing the ability to influence outcomes in our bottom line at an enterprise level. And to Deanna's point, you have to have those key alliances. So Dr. Kalarafi is spending a lot of time with roadshows, getting the right community of physicians and finance people together. And when we're making decisions, because we can't do everything with this infrastructure, we're getting Deanna and a large group of our senior execs together to pick the opportunities that we go after and to help us develop the roadmap.
Very good. Deanna, we talked about and we've seen discussion about the change in healthcare to a value-based system away from fee-for-service. People are moving as fast as they can into that world, whereas the payment model may not be changing, in step. Is it a concern to be too far into the new world when the payments haven't gotten there yet? And is there any hedging? Does hedging make sense to any degree? And what might technology's role be, or the CIO's role be in being a voice for hedging? I don't know. What do you think?
No, you're absolutely right. You've got a foot in both camps. And how do you build that innovation? But like you said, don't get too far ahead of yourself, because you never know where it might take a turn and the course would be modified. So it's a very difficult balancing act. And again, I wish I had the secret message to say, if you just do this, it will be perfect. But unfortunately, I don't.
Okay. I think one more question we have about time for. Let's talk a little bit about the garbage in, garbage out syndrome when it comes to data. I mean, you can put in all the fantastic systems in the world to do all kinds of incredible things and produce incredible insights, although they won't really be insights if the data isn't good going in. That brings up a little bit of ICD-10 and getting better data, but even if we don't make that switch and we see eternal postponements, there is a concept, there is an issue here of making sure the data is good going in to make the work on the back end worthwhile. Can you talk a little bit about that and what IT's role might be in getting with those front-end clinicians and helping them understand what you need?
I'm going to give that question all to Bill.
Thank you, Deanna.
Lucky you, Bill.
Yeah, so a couple answers to that, and it goes back to governance. So we spend a lot of time in our source systems making sure we have quality data. And whether it's Cerner or EDT platforms, we've got people on the ground that are looking at that. So at the source, we're trying to make sure we've got clean data. Where processes may not be capturing something we need, we'll go back and see if we could do those. As part of governance, it's also critically important to understand at a domain level, because sometimes radiology, maybe we have two systems underneath the covers of that, but we're trying to get business and IT stewards for every system that feeds us data. Because the credibility of what we deliver, this is exactly right, is all in the accuracy and completeness of the information we bring in. And then you need to have the right architecture, staging environments where you're kind of inspecting all of your data for accuracy, completeness, and make sure there's not any crazy anomalies before you promote it further down the architecture. And it's important to have the right tools in place, the profiling tools to make sure that's done. So it's definitely not simple, and the more diversity you have in your infrastructure, the more complicated it gets. So you just need to make sure you're well organized and you've got all your friends kind of out there that will be feeding data, and you've got the right business representation on the team to go back to the point of care if we need to change a business process to correct the data coming in.
Well, that's a great answer. Thank you very much for that, Bill. Well, that's about all we had time for today. I want to thank Deanna Wise, and I want to thank Bill, and I want to thank Graham for joining us, and SAS. I think we had an excellent event. I actually received a message from our good friend, the former CIO of Sharp Healthcare, Bill Spooner, who said, great presentation. It'd be great to hear from you again a year from now and learn about your successes. So maybe we'll have to get the band back together again next year and do this again. Go ahead, Deanna.
That sounds great. And Bill's a good friend, so I appreciate the feedback, Bill.
Good stuff. As I mentioned, you'll receive an email when our archive is ready and a separate registration is required. For those of you who have the CHIME CHCIO certification, if you've asked us to communicate that to CHIME, we will. If you have not, please don't forget to claim your credit with CHIME. Attending our webinars gets you 1 CEU for each webinar attended. Questions, comments, please contact me. Always interested in making these the best they can be. And you can go to our website to view our upcoming schedule and the last 12 months of archives. So with that, again, I want to thank everyone for on the event and thank everyone for joining. And everybody have a wonderful day.